A little bit of background to why we put this session on. So the World Oncology Forum highlighted 3 priorities for cancer care. Number 1 was access to good diagnostics. Number 2, access to cancer treatments. And number 3, access to supportive and palliative care. And the first 2 are self-evident and well recognised. If you don't get good diagnosis, you get late presentation and your outcomes aren't so good. If you don't have access to cancer treatments, then you're in trouble in that direction too. But what's less well recognised is this need for systematic access to supportive and palliative care. So cancer affects every aspect of a person's life and the people they live with and the communities that they stay in. But yet in my clinic, a patient comes in and I'll say, "How have you been this week? How are you?" Now if I ask that open question, I'm likely to get on average 1 concern from that patient. And it's often the really big, severe, distressing concern. If, however, I ask in a systematic fashion, working my way through all the aspects of somebody's life, it doesn't have to be in any great detail, but if I'm systematic about it, I will get on average 10 concerns. That's a massive difference. So this session was put on to highlight this issue, to try and get across how important it is for clinicians to systematically do this. It's not something we should, it's not something that is the patients to worry about. Why should they know what I want to know about? Why should they know that it's important for me to know if they've got worries about their legal issues or their work issues or their financial issues? People don't always think that that's important to healthcare. So I have to signal to the patient that that's really important. So to help us do this, we have some needs assessment tools. And so in the session, I've been presenting the work about the needs assessment tool that the clinician can use. And one of my colleagues, Irene Higginson from King's College London, was presenting the work that she's been doing with the patient outcome scale, or otherwise known as the palliative outcome scale. The needs assessment tool is a simple guide for the clinician in everyday clinical practice to remind the doctor or nurse to ask about these aspects. So it could be aspects about persistent physical symptoms, it could be about psychological distress, it could be about legal worries, it could be concerns for the future, how they're going to manage at work, what information needs they have. So that's about the patient domain, if you like. But then the thing I really like about this tool is it reminds us to systematically ask about the carer. And so often the carer is that unsung hero, the person who never asked to be in this position and whose heart is often breaking as they see the distress of the person they love so much going through this situation. And if they do come to clinic, they can often be sat in the corner and no one's really thinking about how they are. Well, this tool reminds the clinician to ask, how are they getting on with being able to look after that patient? How are they themselves? And then the other thing that I really like about this tool is that not only does it tell me to ask about these aspects, it also then says, well, what am I going to do about it? So all too easily, needs assessments can be a little tick box and we can collect and we can list and we can count them. We can say, oh yes, there's all these needs. But this one says, what am I going to do? Many of these needs can be dealt by the usual clinician in clinic or the GP in the GP practice. It's just a question of knowing that these problems are there. Or it may be something that the GP thinks, actually, I don't have the skills for that. Perhaps it's a problem with activities of daily living, and they think, well, I need to get the occupational therapist involved with that. Well, there's an action associated with that need. Or it may be, this person's got really difficult, complex, persistent symptoms. I need to involve the specialist palliative care people. So it's identifying the problem and it's actioning that problem. Now, to be useful in clinical practice, it's got to be something that clinicians will use. And if it's going to be something that clinicians will use, they've got to see there's a point to it, and they've got to see it's not going to completely derail their entire clinic. So it's got to be something that can be used in everyday practice. And when tested, this tool found it did not prolong consultation times, and it did improve patient and carer needs. So it did what it said on the tin. And the proof of the pudding is that if you look at the completion rate in where it's been trialled, it's pretty good.